Skin is the biggest organ on the body and the most visible. When you're a GP, you will encounter many skin lesions and will have to recognize them. By understanding the pathology and being a pathology superhero, you'll be able to treat your patients better. There are some common entities that you need to recognize in skin pathology. These are seborrhoeic keratosis, skin tags, epidermal inclusion cysts, basal cell carcinoma, squamous cell carcinoma, nevi, and melanoma. Many skin lesions are pigmented, not just nevi, and in this video we're going to learn which ones can mimic nevi and melanoma. Another important concept is that nevi have a life cycle where they mature from junctional nevi and fall like rain through the dermis to become intradermal nevi. Seborrhoeic keratoses are one of the most frequent of skin lesions. They look stuck on, in other words, they're above the level of the skin. Pathologically, they have a monotonous proliferation of epidermal basal cells, which brings us to their other name, a basal cell papilloma. Now, just like in normal skin, these basal cells can contain melanin, so seborrhoeic keratoses are often pigmented, thus they can mimic melanoma. The key histological word for seborrhoeic keratoses is horn cysts. On the right here, we have a seborrhoeic keratosis. It's warty looking, as they often are. They can be mistaken for verrucous warts, and it's raised and stuck on. In this histologic picture of a seborrhoeic keratosis, the round whorls of keratin are the horn cysts. Notice how the rest of the cells have a very monotonous appearance. They are a benign clonal proliferation, and if they become pigmented, the lesion becomes quite dark brown. The second common lesion that I'm going to talk about is the skin tag. Now, these can look like true warts. They are the third thing that can look warty on the skin. The first being seborrhoeic keratosis, the second the true skin tag, and the third the true wart. This is a skin tag. It's kind of soft, papillomatous and raised. Microscopically, there's an epithelial layer overlying a fibrovascular core. This leads to its other name, the fibroepithelial polyp. Here we have a patient with a small cyst on the eyelid. There are many causes of cysts in the skin, but the most common is the epidermal inclusion cyst. This is an epidermal inclusion cyst. It's lined by squamous epithelium and filled with keratin. Often it arises due to an obstructed follicle, and the keratin builds up inside. These need to be excised completely, because if a little bit's left, then they'll recur. Here in New Zealand, we are blessed with plenty of sunshine, and we didn't used to use sunscreen. So people of my age have plenty of actinic keratoses, particularly on the sun-exposed parts of their skin. What is an actinic keratosis? Well, it's when DNA damage happens to the basal cells in the epidermis and they proliferate abnormally. Sometimes this proliferation fills up the whole of the epidermis, and then it's squamous cell carcinoma in situ. If the basement membrane is broken by cells that have accumulated further mutations, then it becomes invasive squamous cell carcinoma. That brings us onto a consideration of malignant epidermal tumours. There are two that you need to know about: squamous cell carcinoma and basal cell carcinoma. This patient has a buildup of keratin on the skin, forming a keratin horn. From the view here, we don't know whether this is an in situ squamous cell carcinoma or an invasive squamous cell carcinoma. This is a section of an ear which has a similar lesion. You can see the cartilage down the bottom and then the tumour sitting in the centre of the excision. It looks mostly dark blue, but can you see those bright pink areas of keratin within it? Both those were examples of squamous cell carcinoma. They usually arise from actinic keratoses, therefore they're found on sun-damaged skin. They can also arise from chemical exposure. For example, chimney sweeps who used to be exposed to tar used to get squamous cell carcinomas of the scrotum. They can recur at thermal burn sites or in association with HPV infection in the setting of immunosuppression, so for example in kidney transplant patients. The outcome of squamous cell carcinoma depends on the stage, in other words, the level of invasion, the depth of invasion. Also, the presence of perineural and vascular invasion will indicate whether or not it's likely to metastasize and also determine outcome. The key words when talking about squamous cell carcinoma are keratin pearls and intercellular bridges. This is a closer section from that squamous cell carcinoma of the ear we saw before. The pink areas in the middle are keratin. They're forming keratin whorls. Around the edge we have the malignant squamous cells. And the little dark blue cells, well, they're an inflammatory infiltrate because all the antigens produced by the cancer attract inflammation. The second epithelial tumour we need to know about is basal cell carcinoma. There are several types of basal cell carcinoma, and that affects how it looks on the skin. The classical type that we think about is the nodular basal cell carcinoma. It's the firm, white, pearly nodule that can become ulcerated. Sometimes basal cell carcinomas can become pigmented as well and imitate melanoma. The morphea type or sclerosing type of basal cell carcinoma forms a pale plaque on the skin with an ill-defined border. It can be really hard to determine where to take the excision, and they recur more frequently. The final type is superficial basal cell carcinoma. Again, it's a red plaque that forms, and again, the edges are hard to define, so this too has an increased risk of recurrence. In these pictures, we contrast the nodular basal cell carcinoma, seen here near the eye of a patient, the white pearly nodule. This is a typical place for basal cell carcinomas to occur. And then the infiltrative or morpheaform or sclerosing type. This is the red plaque that is difficult to see the edges of and therefore difficult to know where to excise. The key words for basal cell carcinoma are nuclear palisading and basaloid cells. So nuclear palisading reflects the defined edge round this group of cells. It's like they're all lining up like little fence pickets, a palisade. Basaloid means that they resemble the basal cells of the skin, and these cells have a high nuclear to cytoplasmic ratio, so they look purple. So far we've found two lesions that are pigmented but not melanocytic. the pigmented basal cell carcinoma, and the pigmented seborrhoeic keratosis. Let's move on to think about lesions that are more usually pigmented than nevi and melanomas. To my right here we have a very bland looking junctional nevus. The pigment is uniform, it has a uniform edge. This looks really benign. What we see in benign nevi is a squamous epidermis in which nests of pigmented cells lie between the epidermis and the underlying dermis. In the picture here you can see a darkly pigmented nodule sitting with other nodules quite close to the epidermis. This is a junctional nevus. All the nests are contained at the junction between the epidermis and the dermis. The little dark cells down the bottom, well, they're inflammatory cells because this nevus has become irritated. And if nevi become irritated, they can change colour. So not every changing nevus is a melanoma, but it is a red flag sign. This nevus is raised and warty and stuck on. Can you see how it resembles a seborrhoeic keratosis somewhat? This is an intradermal nevus. As nevi age, the nevus cells move from the dermoepidermal junction and fall into the dermis, where they can form a little nodule and raise the surface of the skin. Midway through this process, we have cells remaining at the junction and in the dermis, and this is called a compound nevus. You can see here the cells growing as nests in the dermis, while some still remain attached to the epidermis. And this is an intradermal nevus. The cells have now all migrated, no more cells are attached to the epidermis, and now they're all sitting down in the dermis. And these cells are quiet, quiescent, inactive. No mitoses are seen here. Let's think for a moment about dysplastic nevi. So dysplastic nevi, when they're present throughout the whole body, are markers of melanoma risk. Dysplastic nevi are described as having architectural and cytologic atypia. Now these are quite specific histologic terms, but what it means is they grow in funny ways, and down the microscope the cells, they don't look quite right. We know that about 25% of melanomas arise in nevi, and the other 75% arise de novo from no previous nevus. Let's think about melanoma. I'm sure you know this mnemonic. It helps us remember the red flag signs for malignant melanoma. This picture of a melanoma demonstrates most of them. It's asymmetric, its borders are irregular, it might have changed colour recently. You can see in particular there's a large nodule which is very worrying, and this pigment kind of spreading out like over a floodplain. This one needs excision. When pathologists look at melanomas, they assess the risk for metastasis. Much of this risk depends on the depth of invasion. We call this the Breslow depth. It's the distance between the epidermis to the deepest point of the melanoma. Low-risk lesions are less than 1.5 millimeters deep. There is a related concept, the Clark level. This describes how far through the skin the melanoma has progressed. Now, of course, these are related because a melanoma with a deep Clark level will have a high Breslow depth. In some places, though, the skin is very thin. So Both things are important, but most important is the Breslow depth. The diagram to the right here shows how Breslow depth and Clark level are related. Melanomas that are Clark level 5 are very deep, and the deeper the melanoma, the higher risk that the melanoma will metastasize and the patient will die. Sometimes we talk about melanoma by their type. You're probably thinking of the classic nodular melanoma. It literally, like the one that we saw earlier, forms a nodule, an asymmetric nodule that's heavily pigmented. But there are other kinds of melanoma. In sun-damaged skin, people get lentigo maligna, also known as Hutchinson's melanotic freckle. It's a type of melanoma in situ, and melanoma, invasive melanoma, can develop in this. Superficial spreading melanoma can look at the start a bit like a nevus, but it has some red flag signs: bleeding, irregular margin, and growing. It doesn't have a nodule yet. And finally, there's acral lentiginous melanoma. These are the melanomas that occur on the palms of the hands and the bottom of the feet. They can be quite flat, hence the name lentiginous, and acral means they occur in the type of skin that forms the palms and the soles. The final tumour that can be pigmented is the vascular tumour. In this picture to the right here, we have a classic cavernous hemangioma, which in this patient, who is a child, is occurring on the face. Many people can get cavernous hemangiomas, and if they become thrombosed and hemosiderin pigment forms, they can become pigmented as well. But of course, these lesions are all benign. We're going to switch gears a bit now. Stop thinking about lumps and bumps in the skin and start thinking about two important diseases, Pemphigoid and Pemphigus. Both of these are immune diseases. Both of these are blistering diseases. The first one illustrated here is Pemphigoid. In Pemphigoid, what happens is that antibodies form to the basement membranes. They attract inflammatory cells, complement is activated, and before we know it, the epidermis is separating from the dermis. Can you see it in the picture here? And that, of course, forms a blister. There's a type of investigation that we can do where we label with a fluorescent dye the antibodies that are deposited on the basement membrane. This is why sometimes in blistering skin diseases, your consultants will ask you to send a skin biopsy fresh. It's so we can do this investigation. This is Pemphigus, another terrible blistering skin disease. It's superficially similar. When we look at the immunofluorescence though, we can see that the antibodies in Pemphigus are depositing between the keratinocytes, and the level of split is higher in the skin. It's between the layers of the epidermis. This brings us to the end of thinking about skin pathology. Remember, there are lots of lumps and bumps that can be pigmented, not just melanoma. And remember that sometimes you might be asked to send skin biopsies for immunofluorescence, particularly if the patient is acutely unwell. By remembering these things, you too can become a pathology superhero.